Welcome to Ortho Reports podcast. Today, we're diving into a case that starts with one of the most common injuries you can imagine, a broken leg. But what begins as a straightforward fracture quickly unravels into a complex medical mystery, revealing a serious danger hidden inside a totally standard procedure.
So what happens when a routine treatment, something that's been used for over 100 years, leads to a rare and really severe complication? Well, this case forces us to look a lot closer at the kinds of dangers that can lurk within everyday medical care, especially when a patient has an underlying vulnerability that changes all the rules.
All right, so our story starts with a 24-year-old woman who has a bad fall down a flight of stairs. The result? A closed fracture of her distal femur. That's the big bone in your thigh, close to the knee. Now, it's a serious injury for sure, but it's also a very common one that orthopedic teams deal with all the time.
To stabilize her leg before she could have surgery, the ER team applied a Thomas splint. You know this thing is a classic. It's a time-tested piece of equipment. Its whole job is just to keep the leg still, reduce the pain, and prevent any more damage while the patient gets ready for a more permanent fix. It's a standard, and usually very safe, first move.
But here's the thing. This patient wasn't just dealing with a broken bone. She also had homozygous sickle cell disease, or HBSS. And that's the crucial piece of this entire puzzle. This genetic blood disorder messes with your circulation and your ability to heal, and that dramatically raises the stakes in any kind of medical situation.
So the patient was admitted for care, but this is where the story takes a really sharp and unexpected turn. For more than 2 weeks, a very serious problem was brewing, completely undetected.
Around day 10, the patient started feeling this growing discomfort in a very private area. But as the case report points out, she actually hid her symptoms for nearly 5 days because of fear and embarrassment. This delay in reporting is such a critical human element in this story. It's a huge reminder that patient communication is just everything.
By the time she finally did speak up, the damage was already pretty severe. So the huge question for the medical team became, what on earth went wrong here?
And the finding was, wow, it was shocking. A large necrotic pressure ulcer, we're talking 8 by 4 centimeters, had formed on her labia majora. Now this is a highly unusual place for a pressure sore. They almost always form over bony spots like the tailbone or your heels. This was a true medical anomaly.
So now, the medical team had to become detectives. They had to piece together how a standard splint for a simple broken leg could lead to such a devastating and rare injury in this specific spot.
The first and most obvious suspect was, of course, the device itself, that Thomas splint. How could a tool designed to help end up causing so much harm? And the investigation found its mark really quickly. The report says the splint was creating excessive proximal compression. So basically the ring at the top of the splint was pressing way too hard and continuously against her groin. The report even notes that stained padding on the splint was evidence that it hadn't been monitored well, which just made the problem worse.
But the splint's pressure was only one half of the equation. The other half was the patient's own unique vulnerability. Why did this pressure cause such catastrophic damage in her case specifically?
And that brings us right back to clue number 2, her sickle cell disease. This condition creates impaired microcirculation. The best way to think of it is like a constant series of tiny traffic jams in your body's smallest blood vessels. This starves the tissues of oxygen, making them incredibly fragile. So for this patient, even what might have been modest pressure from the splint was enough to cause massive tissue death.
So, mystery solved. But now the team faced a new, really complex challenge. How do you treat two very different but totally interconnected problems at the exact same time? They had to manage this severe, delicate wound while also making sure a major bone fracture healed correctly.
The team's 2 goals were almost fighting each other. The ulcer needed immediate pressure relief and a ton of care, but the femur fracture still needed to be held stable. This was going to require a very careful and very coordinated approach.
So for the wound, the plan was meticulous. Step 1, get that splint off and remove the cause. Step 2, clean the wound, get rid of the dead tissue, and apply specialized dressings. And finally, step 3, surgically close that severe wound using local flaps of skin.
And this is where the orthopedic solution got really clever. They replaced the Thomas splint with a well-padded slab that didn't put any pressure on the groin.
Then for the actual surgery to fix the femur, they position the patient on her side, that's the lateral decubitus position, to completely avoid putting any pressure on the healing surgical wound. It was a brilliant adaptation to a really complex situation.
And the result of this amazing, coordinated approach? A fantastic outcome. The patient's surgical wound healed completely in just 2 weeks.
So, what are the big takeaways here? Because this isn't just a story about one patient. It's a powerful lesson in patient safety and clinical vigilance for everyone.
The case report states the crucial point directly. This was an avoidable complication. Proper sizing of the splint, adequate padding, and regular monitoring could have prevented this whole ordeal. It's such a stark reminder that even with tools we've used for a century, we can never, ever overlook the fundamentals of care.
The clinical message is crystal clear. We have to be aware of unusual ulcer sites and be absolutely meticulous with how we place devices. But beyond the technical stuff, this case highlights 2 huge lessons. Perform routine skin checks, and maybe most importantly, create an environment where patients feel safe enough to report any discomfort. Because as we saw here, the patient is a key part of the care team.
And that leaves us with a final, vital question. This was called a rare complication, but for the patient who lived it, it was 100% of her reality. It really challenges all of us to think about how we can be more vigilant to prevent the unthinkable before it ever has a chance to happen. Thanks for listening to Ortho Reports Podcast.